of Bioethics Board, for whom palliative care was an issue of great importance. She devoted much of her time to Johns Hopkins, both as an employee and volunteer. She served in the Johns Hopkins University Development Office and raised critical support for oncology department, chaired the Johns Hopkins Bloomberg School of Public Health Council on Population and Family Growth, served as a development consultant for the Children's Defense Fund and Population Action International. In 2003, her tireless efforts on behalf of the university were recognized through the receipt of the university's Heritage Award for Outstanding Service. Ellie's commitments took on deeply personal significance with the death of her daughter, Sheila Hutzler-Rives, who succumbed to breast cancer in 1988. Ellie served on the Berman Institute board until she passed in 2007. And this semi-annual lecture series, which focuses on longstanding and emerging ethical issues in palliative and end-of-life care, would not be possible without Ellie's generosity and that of her family. We are here today to help realize Ellie's vision and that of this institution to advance palliative and end-of-life care systems and interactions for the benefit of all. And in that spirit, I'm very pleased to introduce today's speaker, Justin Clapp. Dr. Clapp is a linguistic and medical anthropologist who uses qualitative methods and social scientific theory to develop empirically tractable frameworks for examining medical ethics. His work focuses on both clinical and research ethics. In the clinical space, he studies medical decision-making in several clinical settings, including surgery, critical illness, and dementia, by characterizing interactions about initiation or withdrawal of treatment, or how interactions about initiation or withdrawal of treatment are connected to broader social and cultural processes. This work reframes traditional ethical concerns about clinician-patient communication, clinical expertise, and the use of biotechnology. In the research space, Dr. Clapp has examined such topics as practices of IRBs and on-the-ground tensions generated by pragmatic clinical trials and implementation studies. But without further ado, I'll join me in welcoming Dr. Clapp, and I'll allow him to introduce today's talk. Thanks.
So first of all, thanks for the invitation to visit and to give this talk. Along the spectrum from like career retrospective style talk to work in progress talk, this is more towards the work in progress side. I will try to give it some broad context before I begin though. So as Alan said, I'm an anthropologist by training. As such, I'm often torn between doing what you might call social science of bioethics, where you kind of turn the anthropological lens onto bioethics itself, versus doing social science in bioethics, where you're using the anthropological toolkit to help along bioethical initiatives. And this talk is a part of a line of work I've been pursuing over the last couple years, in which I've really trying to do both of those things at once. Specifically, let's see, how am I advancing my slides here? There we go. Specifically, I've been examining the ways in which bioethics views language and social interaction. For instance, I've argued that bioethics often tacitly views language as essentially a means for individuals to describe how they see the world to each other, a view which I think can obscure how uses of language derive their significance from social situations. And so what I'm going to present today is an extension of that general argument. So the structure of this talk is that I'm going to first examine a particular tendency in how bioethics views language and social interaction. So this is going to be the sort of anthropology of bioethics portion. And then I'll explore some dynamics that play out in clinical communication that I think are in danger of being overlooked because of this tendency. So to do so, in this second part, I'll draw on some ongoing ethnographic work taking place in several medical intensive care units, or ICUs. So in covering this first section, I'll be mostly kind of reading some written remarks. And then in the second section, where I talk about this work in progress, empirical research, things will become more sort of visual and schematic, and I'll be talking more extemporaneously. So hopefully the transition between the two sections isn't too jarring. The tendency in bioethics that I want to discuss in this first part is a tendency to describe the social interactions undertaken in response to medical events of various sorts as being essentially matters of valuing, preferring, understanding, believing, desiring, and so forth. On the one hand, I think this tendency helps our field. For instance, it allows bioethical theories to appeal to moral philosophy's fondness for abstraction and deduction, to social scientific paradigms that privilege cognition and intention, and to the colloquial sensibilities of practitioners. However, I also think this tendency can cause us to overlook some of the most interesting and perhaps some of the most ethically consequential aspects of clinical interactions. So the crux or the basis of my argument is that to say someone values or prefers or wants or believes or understands, et cetera, something is an event of typification. In other words, it is to characterize that person as exhibiting the kinds of attributes and behaviors of someone who values, who prefers, et cetera, that thing. And this is the case whether that characterization is being applied to oneself or to someone else. And this event of typification occurs in particular circumstances, and its significance is in how it alters those circumstances. But what often happens in bioethical discourse is that this event of typification and all of the social complexities that go along with it disappear. So I'll discuss first how this occurs in two veins of bioethical theorizing, first in moral philosophical accounts of autonomy, and then in accounts of medical decision-making, which draw more or less explicitly on decision theory. And the reason I focus on these two bodies of work is because I think they're the dominant ways that the field frames the general objective of ensuring that patients can participate in determining the direction of their care. So first, the bioethical account of autonomy. In Principles of Biomedical Ethics, Beecham and Childress define autonomy as the ability of an agent to hold views, to make choices, and to take actions based on their personal beliefs and values. While in early editions of the text, they at times invoke a process of higher order reflection, stressing that such beliefs and values should be accepted by the agent as their own, in later editions, they deny that this kind of self-endorsement is a necessary part of autonomy, arguing that this would set an impracticably high bar for patients and potential medical research subjects. They've stressed more recently that the principle is not autonomy, but rather respect for autonomy, which Childress defines as it is prima facie wrong to subject or attempt to subject the actions, including the choices of others, to controlling influences, and which Beecham calls a pre-theoretical moral imperative. So how did this thin account of autonomy become so influential in bioethics and more broadly? For one, and I think this is widely recognized in our field, a largely negative conception of autonomy resonated with broad concerns about medical paternalism. But second, and I think this is less widely recognized, this negative account is combined with what by the late 20th century had become a commonsensical view of mind and action in American moral philosophy. The bioethical theory of autonomy fits comfortably with what philosopher Margaret Walker calls the theoretical juridical model of ethics. Theoretical meaning that, in her words, moral capacity is pictured as itself a kind of theory within an agent, or at least something the agent knows that can be represented in that form, and juridical in that this personal theory is seen as deductively delivering moral verdicts on specific cases. And so I think it was sufficient for the autonomy framework to merely allude to this basic model. Now, the bioethical conception of autonomy has been heavily criticized both within and outside of our discipline. Critics have primarily argued that it doesn't do justice to the importance of social relations in medical scenarios, especially given that patients are physically and emotionally vulnerable and thus more reliant than the average person on family members and caregivers. Revised theories of autonomy, for example, theories of relational autonomy, have made inroads. Given their quest to give a socially situated account of autonomy, these theories are often depicted as stark deviations from the traditional bioethical model. However, they explicitly maintain the pre-theoretical commitment to autonomy as a moral political goal, and not coincidentally, they also wind up maintaining the same basic model of the agent acting on values, preferences, beliefs, and so on, and sometimes adding norms to the mix. The social in these accounts is treated as a source of inculcation. Agents are still portrayed as containers for values, preferences, beliefs, etc. the task of the theorist becomes one of distinguishing authentic from inauthentic values, preferences, etc., by somehow distinguishing oppressive from non-oppressive social relations. The core of the original bioethical account is preserved, and in fact, defenders of the original framework have argued that these newer theories can be absorbed into that frame. Now to the second vein of discourse, that of medical decision-making. Bioethics and the adjacent fields of health services research and health policy have long had an affinity for decision theory. In fact, early bioethical work on informed consent, for example, engages directly with decision theory. And it's very common in contemporary academic medical discourse for the goal of medicine to be portrayed as aligning or integrating care with patients' values and or preferences, or ensuring that care reflects those values and or preferences. I'm sure most of you in the audience are familiar with these turns of phrase. Typically, these terms are used with little elaboration, but once in a while, work in medical decision-making will seek to define or unpack them. Here, for example, is a discussion of values. Values are ever present. Our hopes, beliefs, politics, and religions about which we appropriately feel emotions provide us with the frame or the lens with which we see the world. Values can be thought of as a form of psychological heuristic. So here a value is posited to be as some sort of mental state. The authors make the move that Gilbert Ryle spotted in The Concept of Mind. Again, what I'm arguing is that to say someone values something or that some value is important to them is to typify them, characterizing them as exhibiting the kinds of attributes and behaviors of someone who values that thing. But here we see an instance of that tendency, which Ryle argued was pervasive in philosophy, and I think is also common in the social sciences, including anthropology, to locate such a typification in a singular intrinsic feature of a person. And so here it becomes a state of mind. Because to characterize someone as valuing something is usually to associate them with a wide repertoire of attributes and behaviors. Value often gets transposed into the mind as a particularly anterior state. For example, here, a lens or frame or heuristic through which other psychological activity proceeds. Preference is a slipperier construct in this space. So here are just two example definitions. Preference of care is defined as a statement that indicates the importance of a specific aspect of clinical behavior of care providers or the organization of care seen from the patient's perspective. And then a separate one, the term preference is used to refer to a person's most favored option after taking into account his or her attitudes toward each option's detailed characteristics. So looking at this first one, defining a preference as a statement would seem to suggest it's an utterance, one that would take place in social circumstances. But then seen from the patient's perspective implies that this isn't only an utterance pertaining to care, but also some sort of enduring mental state. Then in the second passage, we have a person's most favored option. Is this an idea in the head or the referent of an utterance? Its juxtaposition with a preceding process of taking into account his or her attitudes perhaps lends itself to a construal in which the individual is first undergoing a mental process involving attitudes and then indicating their most favorite option via a public utterance, and it's the utterance that's the preference, but this is far from conclusive. Because in contrast to value, one can be said to prefer something quite specific, like eating scrambled eggs or not undergoing a tracheostomy, and thus having a preference is typically associated with a much narrower repertoire of behaviors and attributes. Preference glides in bioethical discourse between private mental state and public utterance or activity. And interestingly, this conception of preference plays out tacitly in empirical work conducted in bioethics and adjacent disciplines, as well as in how that empirical work is discussed. For example, there's a large body of preference elicitation survey studies that carry out some version of the following design. Respondents are asked to imagine that they're experiencing a specific medical scenario, and then they're tasked with selecting a treatment approach, right? For instance, to undergo life-sustaining therapy, like mechanical ventilation or dialysis or what have you in this scenario, or not undergo it. And their selection is reported by the researchers typically as a preference. And it can subsequently be declared that some percentage of people prefer treatment X in scenario Y. The key thing here is that the circumstances of the interaction that produce the response drop out. The response is treated as a report of an inner state of preferring. And here we can see a foregrounding of the view of language as essentially a means of describing one's views of the world. Analogous to revisions of theories of autonomy, in the more decision theory-oriented corners of bioethics, health services, and health policy, there's been some uptake of the idea that patient preferences are constructed. The concept of preference construction was popularized by psychologists based on the results of behavioral choice experiments in which participants made different selections in response to prompts that used different language, but that the researchers deemed descriptively equivalent. And decision theorists inferred from these results that people don't always act based on preferences they develop prior to a social situation, but rather often construct preferences in that situation. And this seems like a radical revision of a core decision theory construct, but it still routes the social through the mental, right? So the formation of the preference, a mental state of some sort, is simply made more proximal in time and place to the behavior or the utterance that it then causes. The notion of preference construction easily syncs with, for example, the longstanding bioethical emphasis on adequate provision of medical facts to patients so that they can then make informed choices about care. So like revised accounts of autonomy, this revision of decision theory has not substantially changed, I don't think, bioethical scholarship or interventions. So whether it's in moral, philosophical work or medical decision-making work, this way of framing the involvement of patients in their care can obscure the fact that the familiar and intuitive terms that we use in bioethical discourse are part of moral frameworks that become more or less relevant in specific clinical settings through complex social processes, achieving effects that are often unpredictable. And then it becomes very difficult to grapple with these effects. And what I'm arguing is that there is a sort of short-circuiting of ethical analysis that occurs. And what I'm suggesting is that the focus of bioethical attention should be less on sussing out patients' values and preferences, verifying their authenticity, examining their implications for care, and so forth, and more on how clinicians, patients, and families themselves do this kind of work. And in this second part of my talk, I'll draw on some ethnographic data to examine how this kind of work actually gets done in practice among clinicians, patients, and families. And specifically, I'll point out a few trends from an in-progress study of how clinicians, patients, and families talk to one another in the medical intensive care unit. Now, the ICU is a setting in which patients frequently lack the capacity to participate in discussions about their care. Nevertheless, legal decisions and decades of bioethical theorizing have formulated the concept of substituted judgment as a way to foster patient self-determination, even while incapacitated. So the substituted judgment standard is the idea that a surrogate should, as Buchanan and Brock put it in their seminal book on the topic, choose as the patient would choose if the patient were competent and aware both of the medical options and of the facts about his or her condition, including the fact that he or she is incompetent. Substituted judgment has generated a couple persistent worries in bioethics, and both of which are illustrative for us here. First, there's been philosophical discussion that has focused on puzzling out the logic of this counterfactual conditional. In other words, how exactly is it in this imaginary scenario that the patient could opine on the state of their own incapacitation, right? So the minute details of this debate, which gets pretty tortuous, aren't particularly relevant to this talk, but it is a particularly striking example, I think, of the tendency in bioethics that I highlighted at the beginning of my talk to focus on language's descriptive content, right? Here, the language of the substituted judgment question itself, rather than on the usage of this kind of language in clinical practice and what it does in those circumstances. Second, there are pervasive concerns about accuracy, the accuracy of surrogates in making proxy selections for incapacitated patients about specific treatments. And this concern is driven in part by a large body of experimental studies in which, just the same as in those studies I previously described, Respondents are presented with a hypothetical medical scenario and must select a treatment approach. But in these studies, in a substituted judgment-oriented twist, they also ask the respondent's potential surrogate to basically guess what the respondent's selection is. And failures of potential surrogates to guess the respondent's selection are reported as failures to predict the preferences of their loved ones. Meta-analyses of these studies have concluded that about 1/3 of the time, surrogates cannot predict preferences. And this has led to widespread questioning of the moral authority of surrogates and to proposals for improving surrogate accuracy, for example, recently through the use of algorithms trained on patient data. Bioethical theorists have in recent years responded to these concerns through revision and reformulation of the substituted judgment standard, arguing that its ethical import doesn't reside in the surrogate's ability to choose as the patient would choose, but rather in the demand it puts on surrogates to, as one article puts it, promote the life the patient valued for themselves. The important thing, states another article, is for theories of surrogacy to respect the complex ways in which surrogates actually make decisions, emphasizing the patient's underlying values rather than trying to select the specific treatments they'd choose or decline. And then in a quite recent article, the author writes that, quote, substituted judgment has the great value currently accorded to it at the bedside because the answer to the counterfactual question is thought to tell us, quote, how to go on with what the patient considers to be her life. In other words, the question is asking about the patient's basic values or what the patient cares about. So alas, here we are back again at values. So how does this kind of activity actually play out in the medical ICU and with what implications? I'm currently working on a multi-sited ethnographic study in several medical ICUs. I'll show you the particular ones in a moment. This study is one aim of a larger mixed methods project. You can see that aim 2 is a sort of quantitative outcomes-oriented piece. But in this first aim, we are basically trying to characterize the use of so-called time-limited trials. And a time-limited trial is a collaborative plan made by clinicians, patients, and families to use life-sustaining treatment for a specified duration and to use particular signs of patient response to then determine whether to continue recovery-focused care or transition to a more palliative approach. I'm not going to talk specifically about time-limited trials in this talk, but I want to kind of set the stage for like the kind of data we have here because it's important to kind of qualify what kind of sample we're getting in this ethnographic piece. So in this ethnographic aim, for which data collection is complete, but we're very much in the middle of data analysis. We followed 52 patients across 6 medical ICUs whose physicians told us they were using a time-limited trial. Here are the different sites. As I said, it's 6 medical ICUs in 5 hospitals in 3 health systems. And these various sites give us some decent variation in patient demographics and staffing models, because there's quite a lot of variation in ICU staffing models, in hospital catchment areas, geographic location, and also importantly and interestingly, in the intensity of the end-of-life care that tends to be given at these institutions as measured by the Dartmouth Atlas. Patient eligibility criteria were as follows. So they had to be patients with acute respiratory failure receiving invasive mechanical ventilation. So it's key to note that these patients were already receiving invasive mechanical ventilation, largely incapacitated when we started collecting data on these, when we started following these cases. And as I said before, basically we would send out queries and the ICU physician, if they responded affirmatively and said, yes, the patient in this room is getting a time-limited trial, we would seek to enroll that patient in the study through consenting their surrogate. And this is the kind of data we got for each case. So we interviewed patient surrogates. Sometimes these were single family members. Other times they were multiple people who all were sort of collaborating in the surrogacy process. We would interview as many ICU team members who were working on that case as possible. If possible, we would do multiple interviews with these individuals over time. We did ethnographic observations, particularly of rounds, but really of as many sort of care processes and discussions related to that patient as we could. We pulled relevant EHR notes that basically for the whole course of the patient's ICU stay. And then we directly observed and audio recorded when possible, so-called family meetings, right? These scheduled discussions that happen, usually scheduled, sometimes more impromptu, where as many of the patient's family as possible kind of get in a room or on the phone with the clinical team to discuss the situation. So it's quite a lot of data for each case. And here's general characteristics of the patients we followed. In addition to just the demographic characteristics, I want to draw your attention to the fact that almost 2/3 of these individuals died in the ICU, and 3/4 either died in the hospital or were discharged to hospice. And lastly, to give you even more of a sense of the kinds of cases we followed, we've found in the analysis we're doing of the time-limited trial component of this data, this ethnographic data set, that physicians tend to say they're using a time-limited trial approach when the patient has a long-term serious illness, and it's unclear whether this acute episode of critical illness will or should represent the end of the road or another bump in the road. Or the nature of the patient's episode is such that clinical protocol would otherwise dictate a more or less defined period of waiting anyways. For example, a patient who has experienced cardiac arrest and there's a waiting period to assess neuroprognosis. Or there are cases that we see where an attending says they're using a time-limited trial where basically all parties acknowledge that the patient will die from this episode, but a delay before formally withdrawing treatment is agreed upon. And we think in these cases, the time-limited trial serves to make this determination to withdraw seem a bit less abrupt and hurried. Okay, so that hopefully gives you a sense of the kind of situations I'm talking about here. And now, in the second portion of my talk, I will I emphasize some findings because there's a lot going on in this data set beyond this kind of substituted judgment type stuff that's happening. And also, of course, that these are preliminary findings. We're still very much in the thick of analyzing this data. So one of the interesting things in tracking these cases that we found that surrogate reports about the patient, these sort of characterizations or typifications that I've been talking about, just as much or more than they're offered spontaneously by families, they're actually directly elicited from clinicians. And indeed, clinicians will also, after these kinds of characterizations of the patient have been made by surrogates, basically congratulate the surrogates for doing so. So you see a lot of phrases like, you've been a strong advocate for Bob or whoever's wishes throughout this process, and so on and so forth. But we found that these kinds of reports, these kinds of characterizations, typically are elicited at a couple time points. Now, this isn't, they do happen other times as well, but these are just some general patterns. First, often early in the ICU course. So the patient has been admitted to the ICU. Maybe it's the first meeting that the clinical team has with the family. And the clinical team will often elicit a kind of very broad characterization of the patient, a sort of tell me about the patient kind of thing, help me get to know the patient. Have you or the patient sort of talked about anything related to their care, and so on and so forth? Broad, right? And then what we see is that later, and remember, most of these patients wind up passing away, unfortunately, as patients worsen, or as they, are in a state of pretty bad prognosis that's not improving, you will see a later family meeting that happens where the sort of grim prognostic update is given and discussed by the clinical team. And in conjunction with that, there is an elicitation of this kind of characterization of the patient. For example, you should start thinking about whether she would want a trach. Oftentimes, these conversations in the medical ICU revolve around tracheostomy. Long-term acute care hospitals will require tracheostomy for patients to be transferred there. And so it becomes this almost metonymic sort of emblem of what will be done with the patient, but it interestingly is very procedure focused. Clinicians will often at the same time say there's no need to make a decision now, right? But you should start thinking about what they would want, whether they would want a trach. Where's my mouse? All right. Now, given these circumstances, right, I want to emphasize, given my emphasis so far as well on the fact that these are events of typifying the patient, that these are really events of moralization, right? That in eliciting these kinds of characterizations, clinicians are really rendering explicit like what it is to be a surrogate, what the task of the surrogate is, what being a good surrogate is. They are of slightly different salience, right? At that first time point, it's this sort of tell us who the patient is, give us the essence of the patient, you're their family member, and so on and so forth. Whereas in those second, more specific conversations, as the patient is unfortunately declining or not getting better, the moralizing task becomes sort of voice the patient's stance on a particular procedure, right? But also, and very importantly, at the same time, even though what is sort of explicitly being said is there's no need to make a decision now, what's being set up is a shifting of the onus onto the family, right? You should be prepared to be the ones that sort of make these more formal determinations. And so that, and I don't get into that too much, we can talk about it if you want, for many families causes a good deal of distress. I think it's interesting and helpful to think about how surrogates characterize patients by thinking about it as two levels or phases of reduction. So when a surrogate reports something about a patient, on the one hand, right, they're taking some collection, maybe it's a singular utterance or behavior, maybe it's a collection of utterances or behaviors, and they're reducing them into this characterization of the patient that's occurring in the ICU at one of these time points, right? So that's reduction number one. But then whatever their characterization is, there's an uptake of that characterization through the rest of their ICU stay, right? And that's where additional reductive work happens. For one, as that report or typification is used in subsequent ICU discourse, as we'll see in a second, the sort of raw material for it actually gets sort of further reduced, and the contextual circumstances that were going on with the patient get further reduced and dropped out. And the other thing that's interesting that happens is that the actual event in which the surrogate makes that characterization, the circumstances of that also drop out or get reduced. Okay, and so I'm going to show both of these sort of phases or levels of reduction in the rest of the talk here. So first I want to focus on what kind of work is being done when the surrogate gives some sort of characterization of the patient, and what is the nature of the reduction that's occurring. There's a whole spectrum of ways that a surrogate can report on a patient. And these aren't mutually exclusive. Oftentimes, the way surrogates characterize patients and their sort of orientation towards their health, towards their illness, towards treatment will include all of these different things at once, right? But what I want to point out is that when surrogates make these characterizations, sometimes they'll directly quote patients, right? So they'll say, right, they're at least making a claim, he said, and this is exactly what the patient said, or she said, and this is exactly what the patient said. When that kind of account is given, usually there has to be some contextual detail that accompanies it to sort of like render significant, like, well, what was the setting of that particular utterance and so on and so forth. Or the surrogate can use indirect reported speech. So instead of directly quoting the patient, right, they can say something like, he said that or she said that, and paraphrase some utterance that they made, right? Now, as I'll talk about in a sec, that involves a little bit more sort of inference and interpretation and reduction, right? Because the surrogate is basically translating what the general import is of what they said in the past. And then there are variations of this, like he expressed that he refused to, et cetera, where instead of using this very neutral term, said, which is the most neutral term we have in the English language to talk about what someone said, right? We're using words that sort of capture the import, the contextual import of that particular utterance. So they're more interpretive, they're more kind of reductive on the part of the surrogate actually giving the report. And then all the way over here, we get this very interesting end of the spectrum where philosophers of language and linguists use this fancy Latin term verbum sentiendi, which basically means a verb of feeling or a verb of perception. And that's when we get things like he wanted, or he wants, or he values, or valued, or he prefers, right? Or he felt that, or that, right? And so on and so forth. But what's interesting is that when we get to that end of the spectrum, we don't really know, per se, what is being kind of characterized or summarized, right? Was it an utterance? Was it something the patient did? Is this based on 20 years of observing the patient doing and saying things, and it's massively synthetic? We don't really know. And so what I'm trying to show you here is that when we're more towards this end, generally speaking, when we're more towards this end of the spectrum, we're really involving accounts that have more circumstantial detail, right, of kind of what the circumstances were when the patient said or did a particular thing in the past. As we move more to this side, we tend to get much less circumstantial detail. When we're on this side, these accounts tend to be less typifying. Now, they certainly can still be taken up as some sort of typification. In other words, if I say he said blah, 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 you might say, well, he's the type of person that says blah, 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 right? But I'm not positing that myself necessarily, right? Whereas when I get to this side of the spectrum, I'm very much doing, I'm encouraging a typification of the patient, right? And the last thing I want to say is this kind of stuff is less common in medical ICU discourse. And this kind of stuff is more common, right? The other thing I'll add is that sometimes in this data set, in a handful of instances, we will see clinicians, and exclusively clinicians, actually set up like some version of the substituted judgment counterfactual question. So they'll say something to families like, what would Bob say if he were here right now? Right? I want you to imagine him sitting on this chair next to us, and what would he say? And even though that seems to be asking for a sort of account of an event of speech, that's very much on this side of the spectrum, because it's sort of tacitly or indirectly, it's asking for a typification. In other words, you're sort of being asked to say, okay, Bob has some essential characteristics such that he would say a certain thing if you were in this situation. Now, for one, right, these reports that are more on the right side are more common because of the manner of elicitation, right? So I talked about the 2 time points when they tend to get elicited, right? Where it's sort of like, okay, you have a few minutes to tell me who Bob is, what's the essence of Bob, and so on and so forth, right? So that's, I think, interesting, right? Is that the manner of elicitation leads to these less circumstantially detailed and more typifying and reductive reports. But what is also interesting is that, at least in this data set, once these kinds of reports are given, or these typifications are given by families, it's extremely rare, really almost never, for them to be probed at all by clinicians, right? To say, okay, tell me more about that. What were kind of the circumstances going on? Or why is it that you say that Bob wants this? And so on and so forth. So they rarely wind up getting elaborated on. Now, why is that? I mean, I have a handful of hypotheses, very much hypotheses. For one, the more reductive the account is, the more it is on that right side of the spectrum, the more kind of easily transportable it is. And otherwise, it's very easy to take some sort of swatch like, Bob didn't want to be on machines. And then for the clinician to put that in the medical record, to communicate that to other clinicians, right? And indeed, we see that extremely commonly in this data set. And it allows for a very high degree of sort of accuracy in reporting these characterizations. So when we actually see like a family meeting that happens and what the family member says, and then we see it reported on in the record, it's remarkably accurate in terms of, you know, the actual words that the clinician is able to sum up that kind of came out of the mouths of the surrogates, right? And the more distilled those accounts are, the more possible that is, right? Another thing that I think leads to a sort of lack of probing of these accounts is a sort of reverence to surrogacy and to the surrogate's characterization. It's very often said in family meetings, you know Bob best. You know, can you tell us more about him, about what he would want, and so on and so forth, right? But another thing that I think is going on a more kind of implicit level is this same thing that I was arguing goes on in bioethics, right? Bioethical discourse, in that these are really moments of typification where a certain kind of like social work is being done. They're taken up as intrinsic features of Bob, right? Instead of typifications of Bob, and all that activity of doing the typification disappears, right? And we just have these sort of essential characteristics of Bob. So it's interesting in this data set because some of these patterns are just so sort of robust, and it's difficult sometimes to get outside of them, but it's interesting to look at sort of so-called deviant cases. And so here, for example, is a very rare case. It might be like the only one I can think of in this data set where this move from sort of reporting on something the patient said to creating some sort of essential typification of the patient is actually explicitly discussed by clinicians and family. And so this is just one EHR note out of thousands of pages of EHR notes that we have. But the attending writes, after inquiring about the patient's stated values, so in other words, the attending inquired with the patients, with the family. Family stated that patient is stating that he wants the breathing tube removed, but are not sure whether this represents discomfort with the tube or a value statement about never wanting to have intubated, to be intubated in the future, right? So here we actually see sort of an explicit acknowledgement of like, well, what sort of disposition or typification of Bob will we take from this indication that he wants the breathing tube removed, right? All right, so I talked about that like first level or phase of reduction, and now I want to move to this second level of phase or phase of reduction, where, as I said before, not only does the patient's sort of prior utterances and behaviors become further reduced and distilled and typified, but also the circumstances of that typification as originally given by the surrogate become reduced or even kind of disappear entirely. So it's interesting that while, as I said, clinicians are very reluctant to sort of probe or be perceived as challenging in any way the kinds of characterizations that surrogates make of patients, right? But once they're out there, they're then very much like fair game. So clinicians, at least in this data set, do not hesitate to draw on those characterizations to either suggest directions for care or sometimes very much to directly challenge what families are deciding to do. And we'll see some of that in a moment, right? And when they get used in this way, they tend to become more typifying and more reductive. So so what I'm saying is that as time goes on and these kinds of characterizations get used, they move to the right over time. Okay, and so here we will see that this is just a very parsimonious example, right? Here's an instance where in the EHR, here's an attending reporting an early conversation. In other words, when the patient just has gotten to the ICU with the patient's daughter, okay? Per daughter, he had expressed to his girlfriend he would not want to live on a ventilator. So that's like characterization number one, right? So he had expressed, so we're sort of like in this territory here, right? We're getting a sort of indirect account, presumably of speech, though this is a patient who's been incapacitated or, to a certain degree for a long time. I don't know to what extent this was actually articulated. We don't know from this statement, right? He had expressed to his girlfriend he would not want to live on a ventilator, right? So we get one of these kind of verbum sentiendi type things, but we can see here that there's some sort of interaction that has happened. There we can see that the interlocutor is his girlfriend, and we can see that some sort of stance was conveyed specifically about being ventilated. Then, just later in that note, the attending says, they had prior discussions where he did not want to live on a ventilator and live in this way. Okay, now we have just prior discussions, the interlocutor has dropped out, where he did not want to live on a ventilator. The notion of him articulating this in any event of speech is gone, right? And live in this way, it sort of begins, as I'll show in a second, to get kind of stretched to the present circumstances. And then we interviewed this same attending a few days later, and the attending told the ethnographer that he subsequently asked the daughter, "You're already telling me he didn't want to live this way now. What is the expectation going forward?" So here we can see the kind of challenging of families based on this characterization, but we can also see that continued rightward shift, right? Now we just have a sort of essential characteristic of the patient. There's no event of speech, there's no interaction, there's no interlocutors, and so on and so forth. They've all dropped out. What can also interestingly happen as this reduction occurs over the course of the ICU stay is what I've not terribly eloquently just started calling typification stretching. In other words, the sort of breadth of the typification will expand as it gets reported over and over again. And here's one instance of that. So a fellow reports in the EHR that the patient, and this was even before the ICU stay, declined excisional lymph node biopsy due to fears of complications before his quote unquote acute worsening. So here we have a quite specific procedure, right? We have the fact that it's being declined. Again, we're in that kind of nebulous, indirect reported speech territory. Presumably the patient said something, but maybe this was a shake of the head, who knows, right? But there's some interaction that happened, right? A specific procedure was declined. And then we have this kind of typification of the patient being afraid of complications, okay? But then the fellow later on has a family meeting and reports on the family meeting and reports telling the family that given the patient's hesitancy to undergo procedures, and he's referring back to this event because this is really the only kind of interaction that's happened so far, he proposed another pathway of comfort-focused measures. So in other words, he proposes to the family a shift to a more palliative approach based on a hesitancy to undergo procedures. So this interaction involving a quite specific procedure has now been stretched to a general hesitancy to undergo procedures. All right, I also said that another way that things get reduced, right, in this second phase of reduction is that the circumstances in which the surrogates actually have created that typification, right? And I went over that those are quite particular circumstances also will drop out completely. And this is another instance when looking at like a deviant case is interesting because this is, again, just like the one instance I can think of in this whole data set that I've discovered so far where a family actually challenges and goes back and reinvokes the circumstances in which they gave that original typification. So just to give a little more detail for this case. So this is like a family, the main surrogate is the son. His father is admitted to the ICU. On the first day that the patient's in the ICU, a family meeting happens, and the patient's wife says that he would not want to be supported by machines. That then gets put in the medical record, and it kind of carries through the patient's whole course of care, and it keeps kind of getting reinvoked. The patient worsens over time. The team internally thinks that the prognosis is very poor and thinks that things should sort of get shut down. The family, even though they have made this characterization that he would not want to be supported by machines, right, keeps kind of moving forward with so-called restorative kinds of care, right? And so the clinical team repeatedly kind of reinvokes this would not want to be supported by machines typification to suggest, right, that things should move to a more palliative approach. However, eventually, so the family kind of continuously resists the use of this kind of typification, though. And then eventually, what happens is you can see this is in a family meeting a few days later. And a resident says, okay, what would we be talking about basically if we continue along this path is that would involve doing a tracheostomy because he can't be with the breathing tube in his mouth for more than 7 to 10 days or so. So it would be an invasive procedure, et cetera, et cetera. And it sounds like those interventions might not be things that he would want based on what you have told us. Okay. And then the son says, I understand, but you wasn't here. My mom saw him. She's talking about the first time the mom saw the patient in the ICU, mechanically ventilated, et cetera. And mom was shocked. And I mean, I knew what it entails, but she wasn't prepared for that. And that's the issue here is that we thought he had been through enough as far as invasive treatment, and we just didn't want to stress the body anymore. We just thought he'd been through enough at that point. So right? He's going back and saying, these are the circumstances in which we gave that original account, right? And it's because mom was shocked and we were just like, whoa, slow things down, right, at the time. But then he says, and so we need to talk about this. We really, really need to talk about this. So the last thing I'll touch on is that as I said, there are a couple common circumstances for these kinds of surrogate reports. One is in these kinds of early conversations where there's this tell me about the patient kind of thing that happens. Interestingly, it's extremely repetitive, the kinds of sort of characterizations or typifications that get made by families. It is generally some version of he wouldn't want to be on machines, she doesn't want to be a vegetable, she's a fighter, she wants to fight, that kind of thing. This is probably a topic for another day or another conversation, but it is interesting how after decades of emphasis on advanced care planning, we see the same like very general kinds of characterizations come up again and again and again and again, the same handful of them. And then later on, it becomes this would she want to trach kind of conversation, right? So this sets up this sort of deductive task of taking this very broad typification and applying it to this very specific procedure. So what I want to point out is that I talked earlier about the theoretical juridical model, and in bioethics, the tendency to think that there is this deductive task where people sort of carry around their values and preferences and then apply them to specific procedures. But we can see here that that task of deduction is an artifact of what happens socially in the ICU. In other words, it's produced socially, right? Because of you get this typification that's increasingly reduced, that becomes a sort of essential trait of the patient, and then it takes work to do that, right? And then that becomes this sort of deductive lens through which later conversations are going to be had, and there's going to be this attempt to sort of apply this broad characterization to this specific procedure. Interestingly, though, what we have found so far is that, and oftentimes it's presumed, I think, in bioethics that like the problem is like a problem of doing that deductive task. Like it's like, oh, we already said that Bob doesn't want to be on, doesn't want to be a vegetable. Well, does having a tracheostomy, is that being a vegetable, right? So you get these kind of deductive questions. We found that that wasn't really the thing that puzzles surrogates, right? Like, so here's an example. What surrogates really struggle with is not sort of matching this characterization to a specific procedure, but just how incredibly indeterminate prognosis is in the medical ICU, right? So here's a patient's wife. Even though I know what my husband wants, it doesn't sound like the options they're giving us are, how can I explain this? Like, my husband didn't want to be a burden. So that was like the typification for this patient, and it carried through the whole ICU course. He's not going to want to walk around with an oxygen tank for his whole life, or maybe be on dialysis his whole life. So she has no problem, no hesitancy saying, okay, he doesn't want to be a burden, and this would constitute being a burden. But I feel like the options we're getting aren't, I'm not sure if they're bad enough that I could say, oh yeah, you wouldn't want that at all. Do you know what I mean? The options we're getting are like, I don't know, maybe it would be okay. Maybe he could still have a quality of life with this, so I guess that's it. And then I have another quote, which I won't read for constraints of time, but here's another one where a daughter characterizes her father as saying that he doesn't want an invasive approach. she winds up being fairly confident that, according to her father, invasive mechanical ventilation would indeed be invasive. Nevertheless, she's puzzled or perplexed here because she says, would he be okay with him being on a ventilator knowing that he'd get off of it and potentially move on? Or is he on this ventilator right now and we're just delaying the inevitable of what could potentially happen to him? So, vexed, right? And then last, I'll just say, interestingly, that when you see the interaction for these patients who passed away, that ends up being the sort of decisive moment in which the patient winds up getting moved to a palliative approach. It's done through these deictic statements. A deictic term is a term whose meaning depends totally on context. So a classic example would be like a pronoun, like the demonstrative pronoun this here, right? So we very commonly see these statements like, she wouldn't want to live like this. And those are like the decisive statements. What's interesting about these statements is that after all this sort of work of typification and applying these sort of propositions about the patient, they're like, these are the decisive statements that we see that are utterly moored to context, right? They're not like an application of one of these previous typifications. And interestingly, they often occur in conjunction with statements like, I don't want her to suffer anymore. So there's like this nod towards substituted judgment, right? Like this is what we should be doing, sort of, but also there's this sort of almost bleeding into what we would in bioethics call a sort of best interests kind of rationale. So I'm going to end with what you'll probably see as a typical social scientist cop-out, and that I'm not going to tell you exactly what's good or bad about various of these trends that I've talked about. I will say that when I do this empirical bioethical kind of work, I don't find it particularly helpful to say, okay, this part was bad and this part was good and so on. I find it more interesting to think like, well, okay, this is how things seem to go. Can we imagine how this might look different? Does it have to look this way? And if it did look different, how, what would it look like and what might the implications be? So I'll leave you with that. And I want to also just acknowledge the many, many people that have been involved and continue to be involved in generating all this data, only a fraction of which I've kind of worked through today. All right, I think we got 3 minutes for a question. Sorry.
Hi, thank you so much. Great talk, fellow anthropologist here. So really appreciate the work that you're doing. I know you said that, on the last slide that you wouldn't talk about, or well, kind of left consequences open, but I wanted to ask about responsibility and how this view of sort of the surrogate relationship happening in practice, what implications those have for responsibility. So for example, I could see someone taking, let's say, a reductive view of that quote where you show the stretching, the stretching as saying, oh, this doctor did something wrong, and so they're at fault. So how does responsibility sort of come up in this view of the sort of decisions happening as part of this kind of social interaction?
Yeah, it's interesting. I gave a sort of version of this talk last week, and there are a bunch of clinicians, including ICU clinicians, in the audience. And when it came specifically to that stretching piece, they were like, well, I recognize myself doing this now that you said this, but I do it like for these reasons. I'm trying to help the families make sense of the situation and so on and so forth, which I could totally see, right? And I think it very much depends on like the particular circumstances. I do think in general, the fact that these accounts are so heavily elicited, which I guess shouldn't be surprising in the sense that substituted judgment as a legal standard and so on and so forth has been around for a while, but the degree to which clinicians sort of make this work happen was striking to me and somewhat unexpected to me. Like, you read bioethics literature, you get the sense that this is just, of course, how surrogates like think about situations, but a lot of the time it's really clinicians very much sort of encouraging this this type of work to happen. Depending on the circumstances, I do feel like in regards to responsibility, for example, at those later time points where it's like the trach issue and you get this conversation that's like, well, you don't need to make a decision right now, but start thinking whether Bob would want a trach. Like that to me is pretty clearly like a shifting of responsibility onto families. I don't think in that particular way, it's done very tacitly. It's not necessarily terribly transparent how it's happening. Some patients will, or some families will actually kind of react violently against that. And that's like when you'll actually see some open conflict. They'll say, you're asking me for a decision, right? They'll sort of interpret the pragmatic implications of what the clinician is saying. But a lot of other times it would be, we would interview the surrogate and they would just be like really stressed out at that point, right? I don't know, because, Bob didn't say what he wanted, whether he wanted a trach or not, as if that would be like a thing that would be possible to operationalize, right? And so I do think that the responsibility thing is a crucial element of it, and that much of the judgment of the ethics of this probably rides on like how you see responsibility being distributed. So I think it's a salient comment. Yeah.
That's great. We're at the top of the hour, so everyone please join me in once again thanking Dr. Clapp.
Thanks.